Welcome back to another NCLEX question of the day. This time, we are covering a high-risk pulmonary case involving COPD exacerbation and acute respiratory failure. This is an important topic for the NCLEX. Let's begin. A 67-year-old male with a history of COPD, hypertension, and type 2 diabetes is admitted to the ICU with severe dyspnea, confusion, and accessory muscle use. The nurse reviews the patient's vitals and arterial blood gas results. Vital signs: blood pressure is 148/86. Heart rate is 118 beats per minute. Respiratory rate is 32 breaths per minute. Oxygen saturation is 88% on 2 liters of oxygen using nasal cannula. Arterial blood gas results: pH is 7.25, indicating respiratory acidosis. Partial pressure of carbon dioxide is 68, showing severe hypercapnia. Partial pressure of oxygen is 52, indicating significant hypoxemia. Bicarbonate level is 28, showing metabolic compensation. Which intervention should the nurse implement first? Option A: increase oxygen to 6 liters using nasal cannula. Option B: prepare for endotracheal intubation. Option C: initiate non-invasive positive pressure ventilation. Option D: administer intravenous furosemide to reduce fluid overload. Take a moment to think about your answer. The correct answer is option C. This patient has severe COPD exacerbation with acute hypercapnic respiratory failure. The arterial blood gas results indicate respiratory acidosis with extreme carbon dioxide retention and significant hypoxemia. Non-invasive positive pressure ventilation, such as BiPAP, is the first-line treatment for COPD patients with hypercapnia. It helps remove excess carbon dioxide while improving oxygenation and reducing the need for intubation. Why is intubation not the first step? Intubation should only be considered if the patient does not respond to BiPAP. COPD patients who are intubated unnecessarily have a higher risk of ventilator dependence and complications such as barotrauma and pneumonia. Now, let's look at why the other options are incorrect. Option A: increasing oxygen to 6 liters via nasal cannula is incorrect. High-flow oxygen can suppress the hypoxic respiratory drive in COPD patients, leading to worsening carbon dioxide retention and acidosis. The problem is inadequate ventilation, not just low oxygen levels. Option B: preparing for endotracheal intubation is incorrect. While intubation is sometimes necessary, BiPAP should always be attempted first unless the patient is unresponsive or has worsening acidosis with a pH below 7.20. Option D: administering intravenous furosemide is incorrect. This patient has no signs of fluid overload. The respiratory distress is caused by air trapping and carbon dioxide retention, not pulmonary edema. Diuretics are not indicated in this case. Key takeaways: BiPAP is the first-line treatment for COPD exacerbation with hypercapnic respiratory failure. Avoid intubation unless BiPAP fails or the patient becomes unresponsive. Do not aggressively increase oxygen in carbon dioxide-retaining COPD patients as it can worsen hypercapnia. Diuretics like furosemide are not helpful in COPD unless there is fluid overload. Did you get the answer right? Let us know in the comments. If you want expert guidance on test-taking strategies, book our crash course for step-by-step breakdowns of high-yield NCLEX topics, test-taking techniques, and priority interventions. Reserve your spot now at NCLEXsage.com/NCLEX Crash Course. Share this with a fellow nursing student. Subscribe for more NCLEX questions and expert breakdowns. Visit our website and our blog for more content. Thank you for watching, and see you in the next video.